Morning, everyone. It's so nice to see you today, and it is a wonderful day. Today is December 11th. It is a beautiful December day, and I'm excited for episode 10, the Healthcare Inspired Podcast, Compliance Connection. I want to welcome to the show my amazing co-host, Miss Maya Turner.
Hello, everybody. Hi.
Hello, Maya. Oh, I'm a little giddy this morning. As you know, it's Orthopedic Day, so I'm very, very excited.
Oh man, yes, most definitely. It's a beautiful day in the neighborhood in orthopedics.
Yes, it is exciting times. And as you know, I have several clients that I work with regularly that are orthopedic that I often say, "Hey, guess what I heard today?" So
Right.
it's fun to share these stories we get from different areas and what we encounter. But I really want to talk to our coders today, give you some confidence, give you those that work in compliance that have these questions that you get sometimes with certain specialties. So we are now starting our specialty track for this season of Healthcare Inspired because we wanted to dig into certain specialties that we deal with our clients that you might have questions about. And so feel free to ask questions, whether it's live or later on. You can submit questions to us. We want to talk about some of these challenges. Now, for today, we have decided to pick on a few areas of orthopedics. So we are going to talk about evaluation and management, some of the nuances with the data section, risk, the problems addressed. We're going to talk about injections and modifier 25, which is another, hot topic that we get. And really just helping physicians understand how to streamline their documentation when their coders say, we can't get paid for this and this at the same time. What can you do to show that you spent a lot of extra work on this service? And yes, there are codes that you can't get paid for separately, but there are times when you did work really hard and this was a complex case and it took a lot of time. So sometimes there are other ways that we can report services that you may not be aware of as a surgeon. Talk to your coders. They have insight. They have guidance from regulatory agencies and things like CPT Assistant that help them kind of organize in their brain what other codes exist that we can put together that really describe what you did. Because sometimes there is just not a code to describe exactly what you did. So we have to get a little bit our think tanks on and think, okay, like this was done and this was done. Let's put this together and let's describe what was done with these codes versus what you might think as a surgeon is applicable. So that's kind of where our brains go as consultants and coders. When we come in as a consultant, for instance, we're looking at, what are you currently billing, your main procedures? What do you need to know about the current landscape of reimbursement? Where are we at? What challenges have you had getting paid? And we'll help you figure out what you can get paid for and maybe just figure out where your documentation can be improved. So we're going to talk first about evaluation and management. And so I think this is a nice conversation that both Maya and I can equally share in because we both love E&M. So let's get to talking about these elements. So let's talk about the first section, Maya, the problems addressed. When you think of orthopedics, what are some of the common conditions that we see regularly in orthopedics?
Definitely the undiagnosed new problem, right? If there is a sprain or versus a break, right? And they have to do workup that's associated with that. But a lot of times, and this is something that we talk about a lot too, is when they come from the ED, that's an E&M. When they come to the ortho, that's also an E&M because they have to do their own independent interpretation of what the patient comes in for. So if they go to ED and they have a film, that orthopedic still needs to make the determination on the method of treatment based upon the film that's presented. So a lot of times it gets really twisted about what is considered bundled when it comes to fracture care, and then how it relates to how the initial visit translates into the fracture care and the orthopedics provider getting credit for what he is making his independent interpretation and method of treatment. So that's a big thing.
Absolutely. One of the things I deal with a lot is the acute complicated and the acute complicated. Those are the kind of situations I deal with personally. And when I think about the differences there, it's hard sometimes to explain to a surgeon. And I had one recently that wanted to make a simple blurb in their documentation for every patient to make every patient acute complicated, even for a fracture that was in the healing phase. They had already treated it. It was already healing, and they were just following up. But because of the age of the patient and concern of future issues, they felt that documenting acute complicated because of the potential for a complication later on that qualified. And I had to gently say, no, that is not what this is intended for. You have to tell us, as Miss Christine Hall always says, shout out to Christine.
Today.
Yes, today. What happened today? And actually, those of you who haven't seen Christine, she has a shirt that says today on it. I need to get me one, but it's true. And we have to be able to talk to our physicians and our office managers, those that have to have these everyday conversations with physicians. It's what you did today. Now, we know for a certain age group or complications could occur for children, pediatric orthopedics. It's a concern, right? I understand. But that doesn't mean that it's going to happen today. What did you do for them today? Today, they're in the healing phase. Today, the injury is not complicated. It might have been complicated previously, but today you've done that great work of helping them in the process of healing their fracture, and they are not going to be complicated. Now, then we come into our chronic conditions, so maybe our level 4s, and we look at potentially if there is, if it's chronic but it's not getting better, it's exacerbated to the extent where something is making it worse, or it's not at the goal of the treatment you've already established, which documentation-wise, we have to establish the treatment plan. We have to establish what our goals are for our patient, documentation-wise. Then as we progress through that treatment of that patient, we can start to see a pattern happening here. Okay, March 1st, they were fine. And we put them on this medication. We said, we're going to follow up in so much time. And if it doesn't get any better, we'll try this. It's not getting better. So they're not at goal. They're not stable. So we need to now further try something else. And that would be an exacerbated, a progression of symptoms, progression or side effects of treatment. Maybe the medication made them worse. Document all that. Then we come and we talk about, let's go back to the low section, because that's just stable.
Yes. Yeah. So I'm sorry.
You're good. So one condition. So let's talk about osteoarthritis, for instance. Maya, what would it take for a surgeon to get from stable to maybe exacerbated osteoarthritis of a joint?
Well, a lot of times when you're getting to osteoarthritis, I mean, that is always going to be a chronic condition, especially when they're an older age. So when we think about the knee pain and it's undiagnosed, or there is treatment for the joint injections that is not getting better, and there's potential for something more happening, then in my opinion, I think that's where you get from low to moderate, because it's progressing, or it's another knee, or there's potential for pathological fractures because they're a woman and their bones are, that kind of thing. So I mean, and I've had many conversations with orthopedists in that regard, because then it becomes complicated because of these potential threats that are related to the chronic problem. And then there's more to do based upon that. They got to look at labs. They got to run more tests. They have to look at film. They have to do more in that regard. So that would be how you would get from low to moderate.
Exactly. And so then we talk about, the high level. Now, I have some of my orthos that do deal in the osteoarthritis world a lot. Their whole goal really is to assess the joints to make sure, does this patient actually need an arthroplasty? Do they need to go get a total joint replacement? Maybe they've tried other methods. They've tried a scope first. They've tried arthroscopy. They have tried NSAIDs, non-steroidal anti-inflammatory medication like ibuprofen, 800 milligrams. They've tried other things, injections. But now they're at the point where it's bone on bone. They can't do anything else. It's literally, they say severe end stage osteoarthritis of the right hip, for instance. Now that's what I want to see. I want to see the word severe. It really is helpful for those of you surgeons out there. I do tell my coders, they don't always have to say the word severe. They can indicate severity other ways, especially if they are concerned and the mobility and the quality of life, the the bodily function is in danger. Those are other ways you can describe severity without saying the word severe. But yes, of course, we would always want to see that word by our physicians making that clinical decision to go from, yeah, it's okay, to know it's severe exacerbation. It's slightly exacerbated versus severe exacerbation to get us to that high level. But even then, right, we have 2 of the 3 elements we have to meet to get a level. We know this. So we have to have something else to make it a high level. We can't just say, oh, they have severe osteoarthritis, it's a 5. No. We have to get there. So data, we'll talk in a minute. It's not quite our friend in orthopedics as often, but we'll talk about when it can help you. And then the arthroplasty being a major surgery, not always gets you a 5 until you tell us the risks. So there is my other best friend, is the risk area. So
Absolutely.
I want to see the risks. Now, Maya, define for us what it means, the risks of having this procedure. What does the documentation need to show as far as risks?
That is something that we all struggle with because, again, we have to always think about what it goes beyond the implied risk for any surgery. The doctor needs to document, or the practitioner needs to document what goes beyond what standardized risk that this patient has. If they're diabetic, if they have other chronic conditions that can affect the healing, then you need to state how this would adversely affect the outcome of the surgery or the potential surgery that's related to healing and or post-operative care. That has to be in the note, especially to get the high level of E&M, right? So, I mean, when you have, multiple fractures due to an MVA, that's different than a total hip replacement that may not have any risk because they're healthy otherwise. There's no chronic conditions that they're addressing. But when you have a condition that is life-threatening or even potentially riskful in a management section, then it needs to be documented how the physician sees the complexity of the care if it's not addressed, and the potential of what could happen when it's addressed. So you have those types of things that really kind of orthopedics doctors don't like to write. They're sick. They need my care. And it's just like, no, you need more. Otherwise, it's going to be bundled into the procedure.
Yes, and actually later today or this morning, I get to talk about defensive documentation. I'm putting on a webinar for another organization on defensive documentation. I'm going to give examples of that. And so if your organization is needing a defensive documentation webinar for your team, let me know, because I love talking about it. It's one of my new presentations for 2025 that I'm starting to release early to other organizations. So let me know. Now, talking about the risk area as well, there also is the there is the element of when they are too risky to have the surgery. That also is an element. And I think that sometimes not always utilized by coders, or they don't see it sometimes. Because when I'm auditing, I see it and then they give them a 4 and I'm like, no, it's a 5, because they literally told me the severity is the patient is very risky. They had the clearance and they still can't do it because they, sometimes, you have the clearance, you wait for that. The decision hasn't really truly been made yet until they get the clearance. But then they come back and say, oh, no, we're going to let you try this instead. It's just not a good idea right now. And they tell you why. And there's risk to you, and tell me the risks, not just, there's risk of infection. There's risk of that with everybody. I want to know what's risky for your patient, that patient you're looking at right now. That's what you're getting paid for in that encounter. You're not getting paid to tell me what is risky in surgery in general. We know that. So You're getting paid for that patient on their claim, their Medicare number, whatever is being used. It's that person's information you're getting paid for. So what is true for your patient today? So that's kind of the synopsis there. Now, the other side of the coin is the middle part when we think about the data. Now, some specialties are not going to be heavy with data because they don't really have to order a lot. They get it brought to them. But then there's the element, okay, if something is brought to you, like in orthopedics, an MRI, a CT scan, you look at that. You're going to document your own independent interpretation. You can count that alone as one category in the data and still get your level 4 data because you only need one category if you have that allocated. Now, if you want to get a level 5, you got to have 2 categories met in the data section. So let's say, for instance, you had looked at an MRI that came to you from a patient. You did not bill this MRI out of your billing system. You're just reviewing it and you're providing your own independent interpretation, what you see going on, your interpretation, not what the previous radiologist interpreted, and you're just repeating what they said. I see that a lot. I mean, how many times have we seen these surgeons or these physicians just restate what the radiologist already said? I can see the report from the radiologist. I can see you literally just repeated what they said. But there has to be some wording in there that tells me you did an interpretation yourself. Now, maybe it is similar, and that's fine. I'm not going to judge you. I'm not going to be like, oh, you're wrong. You're lying. I want to see evidence that you're telling me I independently interpreted this, and this is what I see. And try your best to make it different to some extent than what the radiologist said, just from a auditing perspective, because it's not only me looking at it, it is the insurance company, someone who doesn't know you, doesn't know your thought process, that might interpret that differently. Just, my 2 cents there.
Yeah, I mean, I think, also when you're dealing with independent interpretation, I always like to see the words personally reviewed and then the outcome of the personal reviewed and the date that the item and or image was taken. I personally reviewed the MRI from da 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 da. And I think another thing that we probably need to discuss too is how a provider can get 2 bullets or 2 of the elements by talking to the person who took the image or the person who did the workup in the ED. When you have intent to have a conversation, even the AMA says if you have an intent to have a conversation, if it's documented in the record and they've already independently reviewed it, that is a higher level when it comes to the data. So if you have a dangerous or a potentially risky patient, and also want to talk about anesthesia, right? Anesthesia, if it's a P4 or a P5 or a P3, you got some things that are going on there for anesthesia perspective with the workup. So, I also believe that, having that intention of conversation in addition to looking at the film also helps with the level, especially with the data.
Yes, exactly. And there is a difference between ordering a procedure, reviewing it, and then also providing an independent interpretation. Now, the AMA has updated their wording in the guidelines and their CPT book to allocate the fact that, yes, you have the same test that could potentially be ordered and independently reviewed. Same test. But here's the kicker, guys. It doesn't often happen the same day. So it's very rare that you're going to be able to use that element or that guideline in everyday practice. I have a surgeon who wanted to do that. Wanted to count the order and the independent interpretation. Well, you ordered it 2 weeks ago. You didn't order it today. You're independently reviewing it today, which that was I think the whole intent behind updating that guideline was to allow for these situations where you are the ordering physician. You're not billing it. You're not getting credit for it on a claim form separately, which is where you get paid for. If you're not doing that, then you're getting paid for it in the independent interpretation and the order. That's how you're capturing the work that you did. If you are deciding to bill for something that you did in the office that day, you get paid for it there. You don't get paid for it again in the E&M. That's double dipping, as we call it, right? So it makes sense, right? Logically, but we have to go from, okay, let's talk about this. What makes sense? What did you do? What can you get paid for? You might have done all these things, but hey, guess what? It's getting paid for here. This is where you're getting paid for it. So make those connections for your physician, help them see this is where the payment's coming from and where it's going. And I think if you come across it that way and don't be antagonistic with your physician. Sometimes it can come at you and you don't know how to react. And this is what I see a lot is sometimes coders don't know how to talk to their physicians, but then physicians don't always know how to talk to their coders because they're thinking on different wavelengths, right? So we have to come to that agreement.
Right. I think coders also have to know when to be assertive with their physicians when it comes to the guidelines. We don't tell the doctor how to practice medicine, and the doctor shouldn't tell the coders how to code. So when we as coders have a potential situation, it's all about your reaction and your demeanor. You have to practice a level of communication that is beneficial to both parties. When you effectively communicate, both people understand each person's points of view, and you can have a meaningful outcome if the information is presented in a well-received way. But you as a coder defending your skill set, your wheelhouse to the physician, so in a manner that he understands and is respectful about it, and you respect him for what he's questioning. It cannot be a conflicting situation. It always has to be, okay, well, I understand what you're saying, but here's what I have practiced, and this is what, XYZ. But it's all about approach, and it's all about listening and hearing.
Absolutely. Absolutely. Another area, of course, that we have to explain often is modifier 25 and our injections. Whoa, Lordy. Here we go, Maya. The fun times. I know Maya had the privilege of speaking on injections and modifier 25 at last year's Orthopedic Bone and Joint Summit. And guys, just as an announcement, the 2025 Bone and Joint Summit is scheduled for July 17th and 18th of 2025. So yay! So excited. We'll be putting out some information shortly prior to that, of course. And we do have a physician speaker this year we're excited to have. So stay tuned for more information on that. We are going to talk about this at length. And I wanted to talk about just, we don't have a lot of time. We did spend a lot of time on the E&M section, but I wanted to touch base on a couple things, just reminders. Maya and I think we've talked to her blue in the face to many people on modifier 25. So I don't think that we have to dig any deeper. We've said we've just spoke our piece, and you can download our modifier 25 documentation guide because it's going to give you anything that we would have told you. So I'm going to give you access to that. If you scan the QR code on your screen, if you're watching live today, we'll also put it in our show notes. Please make sure that you go here and get your copy. Yes, it's a small fee, but it's so worth it to have the information, and you get it forever. So you download it once, you get all the updates that keep coming for modifier 25. We're going to be adding more specialties throughout 2025 as we get to them. So stay tuned for more information. So this document, it's like 20 pages. It's going to keep growing, guys. It's going to get bigger and bigger and bigger. So it's going to be an amazing resource for you to have at your disposal. So please download that fact sheet. Now, talking about modifier 20, again, there is a difference. Okay. Yes. A lot of times in orthopedics, you are scheduled to come in for a joint injection. So maybe like March 1st, I always pick March 1st. I don't know why that date is always in my head. I don't know why. So March 1st is my starting point for everything. March 1st is close to spring. So you get this patient in the office, you realize that they have this maybe osteoarthritis or whatever, maybe just joint pain, or it's just a normal knee pain, and you feel like an injection would help them. The NSAIDs aren't working. You've documented that. They're at the point now where it's just really bad. And for them, they need an injection just to try that next. So you say, you know what, let's bring you back for that. And that's the whole goal of that next visit. You don't need to evaluate them again. You already done that. You already got paid for that. You're only getting paid now for the injection. That's it. Now, let's say, for instance, they're like, oh, my shoulder hurts now. Okay. Guess what you got to do? You got to do a workup on the shoulder. Okay. You got to talk to them about their symptoms. You have to get a history, of course, yes. Examine the shoulder. True. You maybe will order an x-ray in the office to see if some deeper is going on. That's normal and customary. You might prescribe medication. Any of those things could be true and still get an E&M because it's a separate condition. It's not part of the workup you already did for the knee injection, for instance, and you're here to talk about that. That's one thing. But let's say it's the same condition. Let's say they come back and you know they're coming in for that injection. But guess what? They're also like, you know what? I think I'm having an issue with swelling and it's just really bad. And you feel as a physician, I'm going to go and get the injection, but I'm going to go in and prescribe them some medication. That's additional workup. That is not part of the E&M level that you normally have to do, that you already did, that's already built into the actual injection. Maya, tell us what kind of work is built into the injection itself. What E&M is already there?
Well, so I always like to, when you're doing, girl, okay, I'm like bursting at the seams. This is like, my wheelhouse, but I'll try to keep it condensed. So I always like to say, do the E&M Snellen test, right? With the procedure. If you can cover the E&M and see the procedure, or if you can cover the procedure and see the E&M, then you're good, right? But again, when you're dealing with a procedure, there is some integral components that's related to when you present for a problem. Are you still having this problem? That's part of the procedure. That is what is needed, right? But if there is nothing outside of what they originally addressed when they come for that procedure, then that's all you're getting. Like Jen said, if they're doing something, if they're doing they're assessing something more, they give a prescription and they'll further evaluate upon return, then that's an indication that they are watching for something and they're looking for improvement on the next visit.
Exactly. And I'll use an example that Betty Hovey always uses that I just love. It's not necessarily orthopedic related, it could be, but a lesion, right? So let's say you come in the office, the physician is not going to just grab your arm and start carving into your lesion. They're going to say, hey, can I touch this? Let me examine this, right? That's part of the procedure. They have to do that. So I just love picturing that because I'm like, can you imagine someone just grabbing you and be like, hey, let's do this? Like, no, they're going to ask you questions. They're going to like actually examine it before they do it. That's what's built into the actual procedure that has a 0 or 10-day global attached to it. And that's when you would add a 25 modifier to the E&M if you did extra work outside of the normal that's required. Easy peasy. So that's it, guys. That's really, in a nutshell, what you're looking for. There may be various scenarios that present themselves, but is there more work than what is required for the procedure? Plain and simple.
Absolutely. Yep.
Let's move on. Good stuff. Okay. So I wanted to really quickly, as we close today, I wanted to just remind everyone we have an amazing tool at our disposal, and that is the NCCI manual, guys. So please take the time, go to chapter 4 of the National Correct Coding Initiative, and we will put this in our show notes as well, just so for you ortho people, if you have that. I talk to coders and directors, and not many of them really know what's in that manual. And I find that not upsetting, but I guess worrisome. I mean, I'm a little upset, but I find it worrisome that those that are supposed to understand these guidelines don't know them. But I will say, I'm going to just say, walk it back. There was a time I didn't know about it myself. But once you know, do something about it. If you are in a position of leadership, it is your responsibility to know compliance-wise what your team needs to do their job. And what they need to do their job is to know about the NCCI manual and to utilize it regularly. So I just want to kind of highlight that because it's something to, be concerned about. Now, there's various things in there. It covers the spine. It talks about the different levels of the spine, how the primary spine code versus additional codes. It talks about something very specific in orthopedics, which is the shoulder arthroscopies when they are bundled. Now, this is a common thing I had to talk to my surgeons about many moons ago, trying to explain why we can't get two arthro procedures on the same shoulder that are bundled. And that's if they're bundled. I'm not talking about one open procedure and one scope. If 2 scope procedures are bundled, that's what the guideline's talking about, right? So you have 2 procedures on the same shoulder, and it says If it is on the contralateral shoulder, which means the other shoulder, then yes, you can unbundle it with the 59 modifier, excess, whatever you use. But if it is in the same shoulder, they're expecting you're already in there, same incision, you're already in there, and that structure is very close. There's a lot of things that are close there, right? But if you're making a separate incision, something that would unbundle it, you got to know your payer is probably not even going to consider it because it's the same shoulder. So it's tough, I know, because you want to get both. But in recent years, one of the ones that was always a problem was the debridement, the 29822 and the 29823, because they wouldn't quite get there in documentation. It was really more of a limited debridement. And that's the other thing. Debridement is debridement. It's really mostly included in most surgical procedures. And NCCI says that in most of their sections. Anytime debridement's discussed in any specialty, it's always, hey, yeah, it's included. But if you tell me more and you tell me why you had to do extensive debridement, which is why they created the 29823 and why that one has been updated recently, to further describe what those structures are you can debride to make it extensive. And I think that's what we miss on education, is understanding those elements of what makes it go from included to extensive. And in general, I think that's what we're trying to get across, is what is included in the work you're already doing and what can you get extra for. Show your work.
If you want extra money, you got to show the extra work, period. That's it. Yeah.
I mean, if I have a client and I'm doing the work, I have a contract in place. So I kind of explain that, kind of like our physicians, they have a contract with the insurance. The insurance says, if you do this, we'll pay you more. So if I have a client and I'm saying, okay, if I do this, our contract states I'm getting this much per hour or this much for this project. If I go above and beyond and it becomes more complex, we'll add on extra fees and we will notify you of those. And so it's the same concept. I'm not going to expect to get paid for my clients more money unless I show that I am doing more work. And we have a conversation about it and we show that work. Same concept. Our physicians, they have a contract with the insurance potentially, and they're saying, if you want more money, yeah, great. Show me why. Plain and simple. It's totally easy to understand when you think of it that way. But it's one of the only industries where we have this, and I'm going to say cat and mouse game going on between the physicians and the insurance company because they're not on the same table. A lot of it has to do with communication and education. So when I hear the organizations, we can't afford to provide education for our coders. Here I go again. You can't afford not to. How many denials do you have? I come in your organization and I see right off the bat how many errors could have been avoided with education.
You can actually see that with just the number of questions that you can ask, right?
Oh my goodness.
Okay. If you're an internal medicine doctor and you have a 60% Medicare population and you say, what levels of services are you typically billing? And they say 2 and 3, you already know that they're losing money because most Medicare patients have more than one chronic condition and they're prescribing meds. So, those types of questions and those types of analysis that are related to the care that you're providing, it makes a difference, and it could be the difference of you surviving or not. But when you think that and you don't know better, and you talk to somebody and you're like, wow, you could have made X, Y, Z, then that could be the difference of you surviving and keeping your doors open or not, especially in today's climate.
Absolutely. Absolutely. Well, want to thank everyone for joining today. We talked about a lot of good stuff, and we hope you have a great rest of your week. We will see you next week. Next week, we are going to be talking about the primary care physicians and their role. And so that's going to be, I'm going to have to say, Maya's turn to talk about, because that's her wheelhouse. I will chime in where I feel like I want to say something, but it's Maya's baby. So we'll talk to you guys next week. Have a good one.